Great part. The sad part is that I am again without my dear friend and colleague Charmine, who is still on service and so won't be able to make it today. But the great part is this community doesn't need anybody. Yesterday, we were unfortunately without our primary facilitators and had to rely on our community to jump in and help. And really a special shout out to Kirtan and Rebecca and everybody else who helped steer the ship yesterday. It was amazing to see how, despite us not being able to show up, that our community was able to jump in and still have a wonderful discussion. I haven't heard the case or know it yet, so I will intentionally cover my ears when that comes up. But I look forward to reviewing it. Today, we'll go back to our usual format of a case presenter and two discussants. So if you have a case, please volunteer to present it so we can learn from you and with you. And keep that coming in the chat. So if you have a case or want to discuss. But one of the discussant seats is filled today. That is because Rafa is finally taking the lead to discuss in the lukewarm seat today. And he's doing that on the backdrop of some personal news, which will take the place of our usual medical reflection today. And I want to just sort of let you know that many of the CP Solvers team members, including myself, are on a journey of growth within medicine, and each of us have so many different challenges. And our hopes are to really put them out there and share with you our journey and our struggles, so that if they can relate to yours, you may find them of help. And so Rafa is going to reflect a little bit on some recent news in his life that will hopefully help you today. All right, Rafa, the mic is yours. And if you have a case, please volunteer to present.
Hi, everyone. So my name is Rafael, and I'm a last year medical student from Brazil. So currently I'm in this process of being ECFMG certified, which is something that we international medical graduates have to do before applying to the residency in the USA. And I know a lot of students like me, they have a lot of struggles, especially financial struggles, because it is so expensive, those tests. Step one costs like a car here in Brazil. So it took me like 4 years to save that money to be able to pay for the test. So I think the lesson here is to actually work really, really hard and believe in your dreams, despite what everyone else talks about you. A lot of people try to discourage me, and yeah, I think we can believe in ourselves and keep thriving that, and we can achieve the goal someday. And also, a lot of things are required from us besides the step one to do like this clerkships at subhires in the US. They require us to do like the TOEFL exam, which I just did last week. And they require us to have like high scores, and it's hard for us because besides being expensive, it can be difficult because there are a lot of students taking the exam with you, and a lot of people talk at the same time. It can be very distracting, but I could do I could perform well and get the score that I needed to do my SOBA in the US. So I'm really thankful for the CP service for giving me this platform to improve my English, not only my English, but my growing as a human being. You know, I think that's the biggest takeaway from this platform.
Oh, such a gem. And it's amazing to see his growth on video in front of all of us. You know, like all of you are getting to know Rafa better and better and better and better. And I think he, as Kushal said, he is in fact a legend. And watching his journey in real time has just been an absolute joy. And cheers to you, my friend. And the next step will be just as rewarding, I promise. Alrighty, y'all. Anyone have a case or willing to jump in with Rafa into the lukewarm seat? I'll pause and mute the mic for 30 seconds and we'll reconvene. Who has a case? Come on, y'all. Recent EKGs, images, mini cases, anything medical, non-medical. I take this time to scroll up and down and get to know the new names that I haven't met yet. 29 people, a lot of whom are very familiar, hiding very case full, I'm sure.
Robbie, if you want, I can present a case instead.
Well, you know I have a trick up my back pocket as always, Rafa, and that is somebody that you that is somebody that you know very well who is encouraging you. Simone, do you want to mute yourself and tell us about? Tell the VMR.
You can do it. You can do it.
What would you like me to tell the VMR crowd, Robbie?
Whatever you want.
Hello, I am Simone. I am on vacation in between my intern year and my second year at UCSF Family Medicine. And I'm often the subject of Robbie's bullying.
Correct. Yes, you have to tell us a little about your vacation. What'd you do?
After my intern year finished, me and all my co-interns rented a house on the beach in Mexico and just spent the week processing intern year, and it was wonderful.
That's wonderful. And you're back home now, huh?
And now I'm back on the East Coast with my family for a few days before going on to night float as a senior.
That sounds awesome. Where you were when do you start? July 1st? Okay. All right. You still have a little time, bask in the break, almost a whole week to go. Alrighty, well, are you bringing this case to us from intern year?
Yeah, this was someone I took care of in my last week who I didn't get the diagnosis about. And then as soon as I left, received an email from the chair of our department who is our attending with clarifying the diagnosis.
Alrighty, let's rock and roll. Rafa, I guess it's you and me solo with our dear friend Simone, which will be a ton of fun. So you're up after every aliquot, my friend. That's not what you bargained for. No break this time, but that's okay. Alrighty, Simone, take it away.
Give me 1 second to ask the person who's vacuuming right outside my door to stop.
Yeah, for sure.
Okay, I'm back. Sorry about that. Gotta find my Evernote. Okay, so the chief complaint, we have a 45-year-old female presenting with 6 days of left wrist pain, redness, and swelling. A little bit more. So 6 days prior to admission, she developed pain and swelling localized to the palmar aspect of her left wrist. She's a caretaker for her grandmother and had recently turned her grandma. And so she associated the pain and swelling with that incident. The pain and swelling worsened over subsequent days. And so 4 days afterwards, she presented to the ED with left wrist pain and swelling. She had an X-ray and a CT, which showed no fracture and normal joint space alignment. So they applied a splint and sent her home. 2 more days elapsed with no pain relief despite Tylenol and naproxen and splinting, and her swelling and erythema progressively worsened and now extended from her distal fingertips up past her elbow, and she had developed numbness and tingling of her fingers as well. She denied fevers or chills and endorsed multiple scratches on her hands caused by her grandmother. She denied a history of gout and denied a history of IV drug use. And I will stop there.
All right, Rafa, right in the deep end, my friend. What are you thinking?
Okay, just to begin with, this is such a chief thing that I don't ever think about it. It's the wrist swelling, something that I've never faced during my clinical rotation. But the first thing that would to me was actually a trauma, but with the CT showing no fractures, I think we could exclude that. And based on the history, like the patient would tell you that they had a fall and then there's this edema associated. But something that I was thinking like, oh, but what could cause like spontaneous edema without a trauma in the region of the wrist? So I thought about tunnel Copper syndrome, and there are many etiologies that could be leading to that. So I thought about pregnancy, but I think it's less common because it's a 45-year-old female, but also things like acromegaly or hypothyroidism, maybe there's something else, like infiltrative disease, like amyloid. So those are the things that I'm thinking about it.
I absolutely love that. I think that you're zeroing in on non-traumatic causes because even though there was some minor trauma, there's no evidence of any consequence of that trauma with the X-ray and the CT. And then you're using your secondary causes of carpal tunnel because the carpal tunnel is located right there and is also one of the reasons why you might have neuropathic symptoms in the fingers. I think if you step back and share a reflection not related to this case, it's incredible how often the physical exam is very helpful in a complaint that is related to the extremity, the arms or the legs. Now, why is that? You know, if you think about the extremities, they are no different than the chest and the belly, except they don't have 1 billion organs underneath them. The skin is located in the chest, abdomen, and extremity. Bones are located in the chest, abdomen, extremity, nerves, muscle, etc. The chest and the abdomen have the heart and the lungs and the pancreas and the lumen of the GI tract all contained with them. And so whenever you have a chest complaint or abdominal complaint, you have both the structures here, but also the structures within them. And it's not uncommon that pathology in the thorax and the abdomen stays hidden and does not rise to the surface. A myocardial infarction, you cannot see, feel, or smell. Pancreatitis, you usually cannot see, feel, hear, or smell. But the extremities, there's not much space to have pathology. I mean, if you're Reza and you have massive biceps, you might be able to hide the pathology. But in folks, normal walkie-talkie people, you often will be able to visualize the disease state. And here, I think we see that. Unlike the abdomen or the chest, you literally see that this patient has edema and erythema and is inflamed. Now, I say that to tell you that when somebody says there's something wrong with their extremity, the first step is to look, because the look tells you so much. And what I encourage you all to do is to try to localize it into one of 4 compartments. Is it a problem with the skin? Is it a problem with the vessels, like arterial insufficiency, venous insufficiency, or lymphatic insufficiency? Is it a problem with the bones or joints, what's called the osteoarticular apparatus? So osteomyelitis, fracture, septic arthritis, non-septic arthritis? Or is it a problem with the neuromuscular apparatus, where on Tuesday, Aaron is a master of complaints in the extremity, usually when the extremity is either tingling or weak? So which compartment does this localize to? It's actually very hard. We haven't examined the skin. Looks like it's inflamed, so it could be a skin problem. There is edema, which could mean a venous problem. There is a neurological dimension to this case with the numbness and tingling for sure. And the patient is locating the pain at the wrist. And so that could indicate could indicate, good luck, could indicate a joint problem. So every single one of those 4 compartments, skin is red, nerves are tingly, bones hurt, and muscles are potentially, and the neuromuscular apparatus is potentially involved. So which one of them is very hard to know. So that's why I think Rafa's localizing into the carpal tunnel based on the wrist is very, very important. But the key step here is to examine the patient and try to localize the pathology within those 4 compartments. Is there reduced pulses? Is there pain with wrist movement, which would localize to the wrist joint, so on and so forth? So I think the key learning steps here are to outline Rafa's approach to secondary causes of carpal tunnel, but then at the same time to step back and say, which one of the 4 compartments is this disease process living in? Skin, vascular, neuromuscular, or osteoarticular? And that you can only do with an exam. And once we've localized it to one of those compartments, we'll be able to say, okay, what is my differential diagnosis for osteoarticular complaint? What's my differential diagnosis for vascular complaint, and so on and so forth. All right, Simone, back to you.
Great. In aliquot 2, I'll give you the rest of her history and her exam. So her past medical history is significant for hyperthyroidism and anxiety and depression. She has a past surgical history of a myomectomy and a right knee meniscal repair. For her medications, she is on methimazole and hydrochlorothiazide. No allergies, and her family history is non-contributory. And for her social history, she is housed. She doesn't use any alcohol or drugs, and she's a primary caretaker for her elderly grandmother. In terms of her vitals, her temperature is 98.8, heart rate 90, respiratory rate 16, blood pressure 138/93, and oxygen, it was 98% on room air. Generally, she was in no acute distress. Her left upper extremity. So in terms of appearance, it was warm, red, and swollen, extending from her distal fingertips proximally in a streak-like pattern up to her elbow at some points. In terms of pain, her left arm was diffusely tender to palpation and with passive and active range of motion. In terms of her motor function, she was able to actively move all of her digits, though minimally, and she had pain with passive extension of her fingers. She was unable to actively move her wrist, and she had pain with passive wrist movement, though we were unable to assess whether it was worse with joint loading secondary to pain. In terms of sensation, she had diminished sensation on the palmar aspect of all 5 distal fingertips, including the radial, ulnar, and medium nerve distributions. From a vascular perspective, her capillary refill was less than 2 seconds and her pulses were palpable. And the rest of her exam was unremarkable.
Ooh.
And I will copy and paste this exam into the chat.
Awesome. Perfect. Thanks, Simone. Rafa, it's getting hot. Tell us what you're thinking.
Hot and harder. So this patient has hyperthyroidism. So I would be thinking that, but also there's something that is going on my mind right now, like pseudo gout. But pseudo gout is actually associated with hyperparathyroidism. So maybe this patient is developing another autoimmune disease with the hyperparathyroidism. Could explain the increased calcium, hypercalcemia into the numbness, but I think it's less likely. I think there's something compressing the nerves right there, leading to that symptom, leading to the numbness and tingling. But I don't know what to think about it. What do you think? Maybe side effects of the medication, but I'm not sure.
Yeah, no, I love it. I think it's actually very tricky. So if we step back and say, Rafa, you walk into a room and the entire arm is red and swollen. And say you just know that an arm is red and swollen. Forget the rest of the case. Tell us what your reflex thoughts are. Red and swollen arm, that's it.
Oh, I would think about infection or an infiltrative process going on, compressing the structures of the arm, those things, you know.
100%. I think that's exactly right. Whenever you see
maybe skin infection like cellulitis could be.
Yeah, totally. When you see a red extremity, you have to worry about cellulitis. And often all you really know is here, the skin is inflamed, right? It's red. And then the question is, we talked about how the exam can help us localize the disease process. So let's play that game. We see that there's edema, which may be vascular in nature or like a venous hypertension, but vascular causes of edema are unlikely in a patient that doesn't have swelling in the leg. It's very unusual to get venous hypertension in the arms absent breast cancer surgery and stuff like that. So you're like, oh, the edema is probably a reaction to the inflammation. So what else can we use? She has tenderness to palpation throughout her arm, both active and passive. What that means is that her entire arm is under high pressure. Now, when you when you ask somebody to move and it hurts, it may hurt in the structure they're moving, or the entire process, the entire arm may be painful. And it's very unusual for an entire arm to be painful without there being hypertension. So this exam is very concerning for deeper than the skin, elevated pressures. And this essentially comes down to compartment syndrome. So if you see that the patient, it hurts their arm a lot and it's swollen, and even just passively moving their arm causes pain, that combination of features is very concerning for compartment syndrome. And what further supports the idea that there's high pressure is that the capillary refill is low. It means that the blood is not getting to where it needs to be. And so this combination of things, compression on the nerves causing neuropathy, compression on the vessels causing poor vascular refill, a red swollen extremity is very concerning for compartment syndrome. Now, what causes compartment syndrome? There are really only three big categories. One, a fracture, either pathologic without trauma or traumatic fracture, so bony disease. And here we have a CT that's normal. Broken bone or a broken blood vessel. If you bleed into your arm for whatever reason, either you have a acquired or congenital vascular anomaly or an acquired or congenital coagulopathy, or you have an infection. And the infection here would be a necrotizing deep space infection like necrotizing myositis or necrotizing fasciitis. So when you see it, this screams compartment syndrome because there's redness and then there's signs of elevated pressure. Those are vascular insufficiency, neurological insufficiency, and pain with passive palpation. There are three causes of high compartment issues. There's a broken bone causing a lot of edema. There's blood, bone, blood, and infection. And here, there's really no evidence for a coagulopathy or a congenital anomaly, like an aneurysm or a pseudoaneurysm. And as Rafa said, there's concern based on the exam and the redness that there's an infection there. So I think I'd be worried about the possibility there's a deep space infection here. And the question is, how do we make progress? And what infection could be at play? So Rafa, when you hear that, when you hear, oh my God, this could be necrotizing fasciitis, can you just begin to share with us what you would think about when you hear the words neck fasc?
It's very unusual for me to hear about necrotizing fasciitis in the arms because the patients that I see on the wards, it's actually in the buttocks, it's in the pelvic region. So it's basically an infection microbial where anaerobes and aerobes together, they make up these environments that are easier to them to thrive. One of depend on the other. So the pathophysiology is something like that. So yeah, and it's very difficult to treat sometimes. Yeah.
100%. I have nothing to add. I think we can talk more about necrotizing fasciitis if we get there, but I think that's a great place to start. And you're pointing out something unusual. It's unusual for neck fasc to be in the arm. It usually reflects the place where you get cellulitis the most often, which is in the legs. So that's a very interesting feature. But the takeaway from this exam is this person, you have to worry about them. Their limb is at threat. They could lose their limb very quickly because they have no vessels, no nerves, and they can't even move it. So we got to get to the answer soon. All right, Simone, back to you.
I agree. We were very worried about compartment syndrome, but I will clarify that the cap refill was less than 2 seconds, so normal. So did have vessels still. Okay, in this next aliquot, I'll give you the labs. In terms of the CBC, the white count was 8.2, hemoglobin 13.7, and platelets 265. For the BMP, sodium 140, potassium 4, chloride 106, bicarb 25, BUN 11, creatinine 0.54, and a glucose of 99. The CRP was 50, the ESR was 55, the CK was 299. She had a uric acid of 4 and a rheumatoid factor of 3.7. She had a repeat X-ray on admission that showed No evidence of fracture of the left wrist and forearm. Joint spaces are normal with normal alignment. Mineralization is normal. There is no evidence of soft tissue swelling or calcification, which was the same read as the x-ray she had gotten in the ED 2 days ago.
Hi, my friend. We walked into this being very worried about infection and neck fascia. Where are you at now?
Just one clarifying question. The temperature is Fahrenheit. How is that in Celsius? 9.8.
Normal. She had a normal.
Is it? Okay. So she was not febrile. Okay. So when it comes to let me see. It's pretty much unremarkable, the hematology, unless I'm confusing the numbers and the chemistry as well. But the CRP is elevated, although, and we could think about things like infection or malignancy, something that it's causing this inflammatory syndrome. Is the CK elevated, 299? No? Okay, so muscle breaking down would be less likely. And the uric acid being 4, it's high or low or normal? It's low.
Normal.
Ah, normal. Okay. The only thing that I can progress with the data now, based on my personal knowledge, which is limited, by the way, it's going on like a disinflammatory syndrome due to the elevated CRP. Nothing else can show me how can I further progress in this case, you know?
I agree with you, my friend. Most people with really bad necrotizing fasciitis or necrotizing deep space infection have a higher white count, a lower hemoglobin, a higher CRP, and a higher glucose and a lower sodium. All this is part of a score called the Lernick score, LRNEC, which has questionable performance characteristics, but certainly something that we think about a lot. And so if our pretest probability of necrotizing fasciitis was mild to moderate before, it has to be lower now. But the problem is that the morbidity of an untreated infection is so high that even if there's a hint of it, you have to think about it. Does that make sense? We're entertaining a possibility of a very rare but very serious diagnosis. And even though the overwhelming odds, the odds of that diagnosis were just lowered by the lack of a robust inflammatory response, you still have to worry about it. But here, I think you're right, Rafa. We're like, well, wait, we expected her to have much more inflammation than she has, even though she has some. What does this mean? And I think in real life, you would probably still call surgery. You would probably consider cross-sectional imaging of the arm to better understand what's going on. But you might go back and say, you know what? This person has an aggressive response to this process in terms of their exam, but not so much their labs. And one diagnosis that tends to do that is pseudo gout. Now, first, let's talk about gout. The uric acid being 4 here lowers the probability of gout, but does not eliminate it. And the reason that is gout is an inflammatory reaction to hyperuricemia. Over the course of your lifetime, patients with gout have high uric acid, period. But in the setting of an acute flare, that uric acid goes lower because it goes into the joints. So a low uric acid here does not rule out gout, but in a 45-year-old woman without medications that cause gout, a diet implicated with gout, and most importantly, normal renal function, gout is rare. Pseudo gout, in stark contrast, is a notorious mimicker and classically presents in the wrist and is usually associated with trauma. The feature that makes pseudo gout a little bit less likely is most patients have what's called chondrocalcinosis, where they have deposition of calcium in the cartilage. So here, the most morbid diagnosis is necrotizing fasciitis. There's no fracture, there's no blood. Platelets are normal, the coags are normal, hemoglobin is normal. So of our 3 causes of compartment hypertension, there's really only the spotlight left on infection. And are we dealing with a mimicker of compartment syndrome with there being many causes, but most notorious of all, I would say, is pseudo gout. So what would I do next? I think call surgery, get cross-sectional imaging, CT or MRI of the extremity, and then look for chondrocalcinosis elsewhere. Most patients have it either in their pubis symphysis or in their knees. So this may be an instance where you're sending this patient to the CT of the arm, but also for the x-ray of the knee and the pelvis to look for a chondrocalcinosis. So I've shared a lot, Rafa. I'm right there with you. I think that I'm underwhelmed by the amount of inflammation present here, even though it is. But I think we still have to worry about a deep space infection given the morbidity of it. I've talked a lot and I see that you're very hard. Did you come up with anything else that you want to share in the 35 minutes I seem to be rambling?
No, it's just another thing that I would be very curious is to analyze the fluid. Maybe we can collect the fluid of the joint space. And because we could see if there's those crystals associated with pseudo gout, or maybe see if there's any bacteria leading to an infective process there. Septic arthritis, the word that I was thinking.
That's a brilliant thought. And I think this is the value add in real life of your surgical consultants, because just to arm you with the concern is if there is an infection and you put a needle through it into the joint, you might take the joint and make it involved with an infection. So the surgeon will be able to say, I want to get the fluid to look for pseudo gout, but if it's actually infection in the skin overlying the joint, if it's red here and I put a needle and it's infected, I may cause septic arthritis. So it's always very hard. It's very hard in real life to make the decision about to get the fluid or not, because there's this theoretical concern that if you tap an uninfected joint with infected skin, that you might introduce infection there. And I've seen it done both ways. I think that is one amazing thing to do after you've ruled out infection. But I will tell you that a lot of surgeons have different opinions about whether or not you should tap a joint in the setting of overlying skin redness, which makes it a very hard problem to try to solve. And I don't have any good solutions, by the way. I'm just pointing it out there that it's actually, in real life, it becomes very, very hard. And I'll say I'm biased because this is something we see in the VA emergency room all the time. Veterans have a high rate of cellulitis and a high rate of pseudo gout, very common. So I'm living the tension in my life and imagining all my surgery colleagues who would be coming to my aid right now. All right, Simone, back to you.
That's exactly right. So we called surgery first to rule out compartment syndrome, which they felt reassured it was not, and then to consider an arthrocentesis, which they did not want to do due to the overlying skin redness. So the patient was started on empiric antibiotics and admitted for further imaging. I will now give you a lot of imaging. Here we go. I'm going to give you 2 CTs, an ultrasound, and an MRI. So just strap yourselves in. The CT from the ED visit 2 days prior to admission was reviewed. That showed a dystrophic calcified mass measuring 12 by 8 by 7 millimeters related to the pisiform triquetral joint space. Haven't said that word in a long time. No inflammatory changes in the adjacent soft tissues were identified. There was no fracture, and there was subcutaneous fat stranding along the distal ulna. Then the CT on the day of admission stated that that dystrophic lesion was no longer there, but mild hand soft tissue swelling with skin thickening and subcutaneous edema was visualized, which can be seen in the setting of cellulitis. Then we got left upper extremity ultrasound, which showed no evidence of DVT of the left upper extremity. And then we got an MRI, which showed nonspecific edema and enhancement involving the ulnar aspect of the pisiform triquetral joint space and surrounding tissues. No evidence of flexor or extensor tenosynovitis, and mild indistinctness of the palmar scapholunate ligament suggestive of injury, and isolated focal edema of the median nerve at the level of the carpal tunnel.
All right, my radiologist friend, what do you think?
I'm thinking this is really hard, but I think there's something maybe we can rule out, because Simone, they didn't see any gas inside of the tissue, right? So maybe necrotizing fasciitis would be less likely. So we would be more reassured, especially because the patients that I treated with necrotizing fasciitis, they have this pattern of gas inside of the abdomen, you know, you can see on the CT, and we're not seeing these right here in this patient's wrist. So maybe necrotizing fasciitis would be less likely. But also I would think like a dystrophic mass. And things that have come to my mind is like maybe a transient process of hypercalcemia, but I don't know. That's the furthest I can go right now with such a rich article. I'm sorry. We don't have MRIs in our hospital, so this is something I'm not used to.
Well, it's okay because here all the MRI tells you literally is non-specific edema. So, I'm lost right there with you, my friend. And I think if I could reflect with you on why we're lost, is because everything that we're getting is not telling us the answer. But let's all 30 of us, 31 of us, just take a break. 30 of us, because Simone knows the answer. Take a break and reflect on the power of the fact that we still don't know. It's so many labs, so many experts, so many imaging findings that we still don't know. And what that probably means is the most scary disease process is probably not at play. The most scary disease process here is necrotizing fasciitis. And I think that the lack of evidence on CT and MRI is tremendously reassuring. So what are we left with? We're left with esoteria here. We really are. Now, what could that be? What could that be? What you all need to know and reflect on is to take this case and learn from it the unusual presentation of a very common disease, which we'll learn from Simone, like pseudo gout, or that this is actually a rare presentation of something very common. And we'll learn. But if you are in this world of necrotizing fasciitis mimickers, I'd say pseudo gout is up there. My puppy just brought a ball and he's like dropping it at my feet. Not now, buddy, not now. So cute. But the other thing to think about is something very rare. And that's called complex pain regional syndrome or reflex sympathetic dystrophy. Now, what is that? That is a disease entity that is a pathologic abnormality. I just won, Natalia, just one dog. That is a pathological entity. You should look it up. It's called reflex sympathetic dystrophy, RSD, or complex regional pain syndrome. Now, that is essentially a disease of the sympathetic nervous system that results either from idiopathic or from trauma. And what that does is it causes a picture very similar to necrotizing fasciitis with severe pain out of proportion to pathology. And I won't go into that illness script primarily because I think that it's a very rare thing and that it's hard to prove right now. But if I'm making a list of things that make an extremity look very, very, very diseased, as this extremity does on exam, but without robust inflammation underlying, I would worry about pseudo gout and I would worry about complex regional pain syndrome, CRPS. But what about all the other stuff that we just saw? What about the dystrophic mass? What about the signal to the joint on the MRI, the ciriform trigeminal joint space? One, pseudo gout, maybe. Septic arthritis of that joint alone, but that wouldn't explain the erythema and edema everywhere else. Or this patient has a traumatic bursitis or septic arthritis. So where am I? I think this is a reality that we commonly face in the emergency room where we don't know if it's infection or we don't know if it's crystal or a trauma-induced bursitis. And so we often give NSAIDs and antibiotics at the same time. And antibiotics to treat the possible infection and NSAIDs to treat the possibility of pseudo gout or other crystalline diseases. And that's what I would do. I would give this patient antibiotics and NSAIDs and see if she gets better. I would also get x-rays of the knees and the pubis symphysis to look for pseudo gout, but the case for that is less and less with no MRI findings of it. And then I'd start to wonder, could this patient have complex regional pain syndrome, CRPS? But the truth is, I'm a little bit more comfortable now because the most scary thing, necrotizing fasciitis, is probably not at play, which is very, very good. Rafa, any other thoughts?
I was thinking, since pseudo gout is a systemic process, we tap another joint, like the knees, a joint that is very well non-recognizable for pseudo gout affecting that.
Exactly. I think that's a great question. If on exam you find fluid to tap, you should tap it. But if there's no fluid to tap, you won't be able to get data. So the key question is to go back and zoom out, as you said, and say, is there evidence of this disease elsewhere? And if there is, you should get data from that site for sure. The final thing I'll say, actually, Rafa, it's amazing how, when you work with a team, how you can bounce off ideas of each other. One infection that is hard to find at the local site is gonorrhea. In fact, when you get disseminated gonococcal infection causing septic arthritis, usually you don't culture it in the joint as much as you find it in the primary site of exposure. Here, the case for that is lower because there is no arthritis. We don't see arthritis, but it might be something you think about. Hey, should I swab this patient for a more soft tissue presentation of disseminated gonococcal infection? That's possible. But I would say my honest order right now, my actual suspicion without morbidity in fake life, not in real life, is probably complex regional pain syndrome first, because we found nothing else. And then all the other things that are actually actionable right now. All right, Simone, back to you.
Okay, let me just say, I feel so incredibly validated by this discussion. Ultimately, the final diagnosis, based on the imaging, which we read in conjunction with the surgeons and the radiologist, was something called acute calcific periarthritis, which is basically the deposition of calcium hydroxyapatite crystals, and they can deposit themselves in the tendons, in the bursa, in any periarticular space. It is like very often confused or mistaken for gout, pseudo gout, and infectious arthritis. And I had never heard of it before. And the treatment is conservative.
Amazing. You know, I've never heard of this before. Can you teach us what you learned? Like, how did you get there? What did you learn about it? How does it present? Teach us more.
So the radiologist got there based on the CT from the ED visit prior to the admission, from the dystrophic calcified mass. And apparently the same patient had sort of depositions of calcium in other joints in other times in her life, that the radiologists were able to find imaging evidence of.
Holy smokes, yo. Wow. Wow. Rafa, thoughts?
The more I learn, the more I don't know.
I know, right? It's incredible. It's like you're learning how much you don't know constantly. It's absolutely incredible. Wow. Simone, thank you. This is absolutely mesmerizing. And I can see how probably in real life, like very anxiety provoking, but in a really great end for the patient. Can you tell us I know you left. What happened to her? How is she doing? What's the treatment?
Yeah, well, she left last week with naproxen and splinting, and the treatment is just naproxen. So I don't know how she's doing quite yet. She hasn't had another visit with any doctors, but I will keep you posted.
That has to be a good sign. I hope that she has not felt the need to return to care, which is absolutely mesmerizing. You know, I don't know where to go here. I don't know who to, I don't know how to reflect on this because it's such a dizzying journey. So I will rely on my dear friend Kirtan to summarize the case and end with teaching points. And if Simone, you have anything to add or tweak or re-emphasize, please jump on in. And thank you again for just a wonderful case.
Yes, all right. So what an amazing journey. Thanks to Simone for presenting the case and to Rafa and Rabi for amazing discussion. Now we have another entity which we can add to our spectrum and schema. So thanks so much, Simone, for that. So we started with a very common and sinister complaint, someone with wrist pain and erythema. And Rabi very early on pointed us that often extremities are reflection of underlying systemic diseases. So whenever you find something in extremities, it's basically a blessing in disguise kind of thing because you can find out the underlying cause. So we were thinking about what can cause edema, erythema, and everything. So Rafa pointed us that some systemic findings like pregnancy, hypothyroidism, acromegaly, and endocrinopathies, including amyloidosis, can present in this way. But the fact that there was erythema and paucity of pulses also raised the concern about possibility of infections. So must not miss conditions like septic arthritis was high on our radar initially in the discussion. Then Rabi pointed us that what are the 4 compartments we should look for. So we should look for the osteoarticular structures. We should look for the neurological findings. So we should focus on the nerves, how the nervous system is functioning. We should focus on the skin itself. And finally, the lymphatics, how the lymphatics and arteries and veins are working in coordination with each other, because edema can be a system of lymphatic disturbances, right? Then we got the more physical examination findings, and it got more and more juicy along the way. That apart from the edema and erythema, there was diffuse tenderness to palpation along with the reduced range of motion. So this is one of those things that when you have got pain out of proportion to the physical examination findings, it again points to sinister findings. For example, in abdomen, we look for mesenteric angina. And here in the extremities, we look for compartment syndrome, because compartment syndrome can present in this manner. But still, because of the erythema, we were still worried about the deep space necrotizing infections. And we even talked about what can cause it. So some non-tuberculous mycobacteria, Erysipelas, Erysipelothecs, all the chat was running through it. Vibrio vulnificus can cause it. Then Rabi one mentioned gonorrhea can present in this manner. Then Rafa mentioned that what about pseudo gout, right? I mean, usually it occurs in patients who have hyperparathyroidism, but when you have got paucity of the findings on laboratory as well as the imaging studies, you have to consider the possibility of pseudo gout. Because pseudo gout is a systemic process and can at times present in a single joint itself. So we have to be wary of those possibilities. And then Rabi mentioned that if it is indeed pseudo gout, then how we can zoom in? Then we can maybe look for evidence of chondrocalcinosis. And chondrocalcinosis usually occurs in pubic symphysis, in the knee joints. So we can look for that, and then we can we can be guided how to proceed further. Then there was another controversial topic which was brought on by Rabi, that what about tapping the synovial fluid? Now, usually it seems like a very easy way, right? I mean, tap the synovial fluid, culture the bacteria, and there is the answer. But here is the key, that if it is indeed a crystalline-based arthropathy, and what if the intervention itself caused iatrogenic complication and iatrogenic septic arthritis? So it's still a controversial topic. We don't know how to deal with it. And finally, when to summarize everything, that there is nothing on imaging studies, there is nothing sinister in labs, then what it can be. So we have to look for the esoteric entities. So two entities that I learned today, one of them is CRPS, which is known as complex regional pain syndrome. It is sometimes also known as causalgia or reflex sympathetic dystrophy. Usually it follows a prior trauma to the extremity, and following that you get evidence of sympathetic nervous system induced dysfunction. So erythema, cyanosis, loss of hairness, all those sort of things. But finally, Simon taught us that when you have evidence of dystrophic calcification or mass like that, then that can cause what is known as periarticular arthritis, and it often mimics the gout and pseudo gout. So it can, kind of trick us into thinking that it is gout, pseudo gout, or septic arthritis. But indeed, it is a very benign finding. Usually, it resolves on its own by conservative management. So it's good for patients and good for us too, that we don't have to panic when such conditions came. And if we think about this, then we can console our patients, and maybe it will resolve on its own. So thank you so much, Simon. And Ravi, do you have to add any other teaching pulse?
Oh, it was absolutely superb, my dear friend. Superb. A great summary of the journey. And I especially love how you remember who says what, calling out their contributions, which is not easy to do in real time. All right, y'all, it's an absolute delight hanging out with you on a great Thursday, and what a case. I hope you enjoyed it as much as I did, and we'll see you tomorrow for RLR. Bye.